Hello, everyone, and welcome to today's webinar. I just wanted to start by saying happy U.S. Antibiotic Awareness Week to everyone. We are excited to share our third webinar in this series for USAAW today. I'm just going to go over a few reminders before I pass it over to my colleague Mohammed, who will introduce our speaker for today. The topic is Swish and Swallow Antibiotic Stewardship in Dentistry. So, as a reminder, participants are muted throughout this presentation. The webinar is being recorded, but we will have time for Q&A at the end. So if you have questions throughout the presentation, please feel free to put them in the chat box and we will go through those at the end. And you can also raise your hand if you want to ask a question verbally. We'll provide those reminders at the end, but there are going to be several ways you can ask your questions, and we will also be placing links in the chat that you can refer to as we go through the content. So thanks so much again for joining us today, and Mohammed, take it away.
All right, thank you so much, Katie, and hello, everyone. Thank you for joining today's webinar on antibiotic stewardship in dentistry. As Katie mentioned, this is our last webinar in a series of 3 webinars in celebration of Antibiotic Awareness Week that are aligned with the human, animal, and environment health components of One Health antibiotic stewardship. I'm excited to introduce our distinguished speaker for today, Dr. Katie Suda. Dr. Suda is a clinical pharmacy specialist, core investigator, and associate director of clinical therapeutics with the VA Center for Health Equity Research and Promotion. She's also a professor of medicine and pharmacy at the University of Pittsburgh Schools of Medicine and Pharmacy, and associate director of the Center for Pharmaceutical Policy and Prescribing, and director of the Transition to Independence program. Dr. Suda is a national expert in outpatient prescribing patterns and antibiotic stewardship. She received her Doctor of Pharmacy from Drake University and Master's in Epidemiology at the University of Tennessee. She also did postdoc training at Baptist Memorial Healthcare and the University of Illinois at Chicago. Dr. Suda's research interests include antimicrobial and opioid pharmacoepidemiology and effectiveness, and implementation strategies to improve prescribing. She has written more than 190 peer-reviewed research articles in the professional literature and a dozen book chapters. Without further ado, I'd like to welcome Dr. Suda. The stage is yours.
Great, thank you so much for that introduction, and thank you for the invitation to speak today. So I do want to let the audience know, though, I have been ill, and this is my first day back in the office. So if I need to pause the presentation to drink some hot tea or water, I'm sure you'll understand, and don't worry, I'll be back. So before I begin, I want to state that I have no conflicts of interest and relevance to this presentation, but I am receiving funding to support my research program, and these are all from federal sources. And I particularly want to highlight an R01 from AHRQ and the NIH and from the VA, which supported some of the research that I'll present to you today. And because I also do research at the VA, I'm required to tell you that the opinions expressed today are those of my own. And I will be sharing some VA data with you today. So today I'm going to provide an overview of antibiotic prescribing by dentists. And then I'll describe to you the evidence of guidelines as well as some recommendations for indications for common reasons why dentists prescribe antibiotics. And then I'll provide you with some examples of antibiotic stewardship in dentistry. So I believe the audience probably understands this, but to make sure we're all on the same page, I want to make sure you understand that antibiotics are not safe drugs. They're life-saving drugs, but they're also associated with significant harm. Antibiotics are the leading factor in the emergence of bacterial resistance, as well as the development of C. difficile infection. And unfortunately, antibacterial drug development is limited, especially for multi-drug resistant organisms. And antibiotics are a primary reason for ED visits, for example, for patients experiencing adverse drug events. And this is especially true for children. And Dentists are actually a high prescriber of antibiotics. Dentists prescribe 1 out of every 10 antibiotics in the United States, right after family practitioners and nurse practitioners. And this is an important topic within dentistry because antibiotics are the majority of what dentists prescribe. So these are data that we assessed from Medicare Part D beneficiaries. And I know you're probably thinking, well, this is a different population. This is Medicare Part D, primarily older patients. And no matter what data set you use, population level, private sector, prescriptions dispensed, or VA data, regardless of the data source, antibiotics are the majority of what dentists prescribe in the United States. We also have been able to do some comparisons of prescribing rates in the VA between dentists and medical clinicians. Medical clinicians being physicians, nurse practitioners, and physician's assistants. We found that dentists actually have higher antibiotic prescribing rates. However, up until recently, very few antibiotic stewardship strategies have been specifically tailored or focused on dentist prescribing. And as we think forward on how to design these stewardship interventions, it's important to recognize that dentists prescribe antibiotics differently. Dentists overwhelmingly prescribe penicillins, and the majority of these penicillin-based agents are amoxicillin. Dentists also prescribe very few broad-spectrum antibiotics. Less than 5% of all antibiotics prescribed by dentists are broad spectrum, versus about half for medical clinicians. However, dentists are the top prescriber of clindamycin in the United States. And of course, this is concerning because historically, clindamycin has been associated with the highest risk of C. difficile infection. Dentists also prescribe more antibiotics for preventative reasons, for prophylaxis or for pre-medication. We estimate that about 90% of all antibiotics prescribed by dentists are for preventative reasons. Now, regardless of this, we still see, however, that the average or the mean days supply for antibiotics prescribed by dentists are similar to that as medical clinicians. So the mean is about 7 days for each of these groups. And lastly, I think importantly that I'd like you to keep in the back of your mind as we go through this talk is that dentists are uniquely pressured to prescribe antibiotics, not only by the patients that they care for, but also by medical clinicians. And they perceive significant pressure exerted from medical clinicians, and this is greater than that of the perceived pressure by patients. So today I'm going to categorize antibiotic prescribing into 3 major categories. Prophylaxis for distant site infections to prevent infective endocarditis and orthopedic implant infections, which I'll refer to as prosthetic joint infections. Prophylaxis for post-procedural complications. You can think of this as surgical site infection prophylaxis. And lastly, for treatment of oral infections, for acute oral infections. And the first 2 categories, prevention of distant site infections and post-procedural complications, collectively, I'm going to refer to that today as prophylaxis or pre-medication. So first, let's talk about prophylaxis for infective endocarditis and prosthetic joint infections. So first, I want to make sure that we understand that there still is a major knowledge gap that remains. And that is if infective endocarditis and prosthetic joint infection is primarily caused by bacteremia induced during the procedure, a dental procedure, for example, or if it occurs from normal daily oral hygiene, meaning the patient brushing and flossing their teeth. So for those of you who are non-dentists in the audience, the bacteremia induced during a dental procedure or during normal daily hygiene is equivalent, is about the same. Studies have been done demonstrating that. So there have been some data published, and the data linking bacteremia induced during dental procedures and IE are mixed. But I do want to note that the strongest evidence suggests that dental procedures are not associated with prosthetic joint infections. Adding to this confusion, we also know that the definitive evidence on the effectiveness of antibiotic prophylaxis for IE or PJI has not been determined, and that these distant site infections have occurred even when a patient appropriately takes antibiotic prophylaxis prior to a dental procedure. So as a result, when you look at guidelines across many countries, most countries recommend prophylaxis in a select few patients with cardiac conditions. And those cardiac conditions are typically those patients who are at high risk of having infective endocarditis, or those patients who are at risk of having an adverse outcome if they do get infective endocarditis. And for PJI, overwhelmingly, most countries do not recommend prophylaxis prior to dental procedures in patients with prosthetic joints. So some of you who are really in tune to this literature may be thinking, but there's a brand new study out. And I agree with you. There was just a study published, I think a month or two ago, that it was published in a cardiology journal that found that infective endocarditis was decreased significantly in patients who are categorized as being high risk per the American Heart Association guidelines. And this high risk category are those patients that are at high risk of having an adverse outcome if they do get infective endocarditis. So the study found that IE decreased in those patients receiving antibiotic prophylaxis who were undergoing invasive dental procedures. The study also found a non-significant decrease in those patients who are in the AHA category of moderate risk. So this study used an insurance claims data set that I'm familiar, I've used it in my own work, and the time period was 2000 to 2015. So as you think about this overall conclusion, I want to point out some really important limitations to this analysis. So first of all, a lot was happening in our community during 2000 to 2015 that affects not only a patient getting an antibiotic, but also a patient having infective endocarditis. So first, the study included Medicare beneficiaries prior to the implementation of Medicare Part D in 2006. So during this period, which was a third of the study period, these patients were coded as receiving no antibiotic prophylaxis, even if they did receive a prescription, because there was no claim through Medicare Part D, because Medicare Part D did not exist. The study did not adjust for any patient comorbidities, including substance use. And of course, this is really important because during this time period, the opioid epidemic was ravaging our communities and continues to impact our communities today. And therefore, for those of you who are epidemiologists in the audience, there's likely high misclassification of exposure and outcome. So therefore, based on this study, we still are not sure if antibiotic prophylaxis has any impact on infective endocarditis in our patients. So what are the current guidelines? So the AHA and the American Dental Association jointly publishes guidelines on the prevention of infective endocarditis prior to dental visits. The last guideline was actually published in 2007, but there was recently an update to the guidelines published in 2021. So these guidelines recommend antibiotic prophylaxis in patients who are undergoing invasive dental procedures, which is defined as procedures that manipulate the gingiva or perforate the oral mucosa or the tooth periapex. And second, patients must have a cardiac condition at high risk of an adverse outcome if the patient does get infective endocarditis, does develop infective endocarditis. So these cardiac conditions are patients with prosthetic cardiac valves or prosthetic material, prosthetic cardiac material, patients with a history of infective endocarditis, patients who have a cardiac transplant who have developed cardiac valvulopathy, and only certain congenital heart defects. Now, the major update in 2021 to the guidelines was that clindamycin is no longer recommended, even in those patients who are labeled as being penicillin allergic. So the treatment of choice remains amoxicillin for those patients who can take oral formulations, 2 grams for adults 1 hour prior to the dental visits, for those dental visits where an invasive dental procedure is anticipated. In patients who are allergic to penicillin, the recommendation is cephalexin, azithromycin or clarithromycin, or doxycycline. Now, for those of you who are non-dentists, dentists this is prescribing a cephalosporin to a patient who's penicillin allergic is still relatively new information within dentistry. So if you are advising dentists, making prescribing recommendations, you can refer dentists to these guidelines, and there's a very nice flow chart to help the dentist determine whether or not a cephalosporin is appropriate for their patients. So the American Dental Association also has guidelines for the prevention of prosthetic joint infection. And these guidelines state that in general, antibiotics are not recommended prior to dental procedures. And this guideline nicely provides reasoning behind these recommendations. First, that there's very limited evidence that dental procedures are associated with PJI, and that antibiotics do not prevent prosthetic joint infections. The guidelines also talk about that antibiotics, even when used for short duration, are associated with harm, and that any benefit is unlikely to exceed the harm for most patients. And overall, these guidelines really strongly support not prescribing antibiotics in patients with prosthetic joint implants. So some of you may be thinking, well, there's this orthopedic organization and they provide some information, and that's true. The American Association of Orthopedic Surgeons publishes something called appropriate use criteria. And this is a tool that AAOS routinely uses for many of their recommendations where evidence is limited. So years ago, the AAOS convened an expert panel to evaluate scenarios where an antibiotic in patients with a prosthetic joint may be appropriate prior to a dental procedure. Now, frequently when I talk to audiences about this information, they tell me, well, they follow these guidelines. And I want to state these are not evidence-based clinical practice guidelines. These were expert ratings, similar to like a Delphi panel. So these are not guidelines. These are recommendations based on an expert panel. So if you follow this decision aid, there's only 2 appropriate scenarios per the AAOS decision aid where an antibiotic may be appropriate prior to a dental procedure. The first is that the patient is severely immunocompromised and has a history of a prosthetic joint infection which required surgery. And the second is that patients are severely immunocompromised and have uncontrolled diabetes. Now, I also want to make sure that we talk about what is severely immunocompromised. because there's a misconception within dentistry that any patient with diabetes is considered to be severely immunocompromised. But this is defined as patients having stage 3 AIDS, patients with cancer undergoing immunosuppressive therapy. So this is not all cancer survivors, it's only those receiving chemo or other relevant immunosuppressive drugs. Patients with RA being treated with a biologic, patients who received a solid organ transplant, who are on immunosuppressants, patients with inherited diseases of immunodeficiency, and patients who have also been recipients of a bone marrow transplant. But similar to what I just talked about with infective endocarditis, there was also a recent study just published this year that demonstrated that there's no evidence to support an association between invasive dental procedures and prosthetic joint infections. And therefore, antibiotic prophylaxis, the use of antibiotic prophylaxis in patients with prosthetic joints or material should cease, should be discontinued. So what are the guidelines now, or what are the recommendations for how we should prescribe antibiotic prophylaxis? So basically, there's only 2 criteria. First, that the patient have an invasive dental procedure. Again, that's manipulation of the gingiva or perforation of the tooth periapex or the oral mucosa. So a dental procedure criteria. And then patients have one of those those cardiac conditions of having a high risk of having a poor outcome if the patient does develop infective endocarditis. So the largest category there being patients with prosthetic valves. So what we found was that 77% of antibiotics prescribed prior to dental visits were unnecessary, were prescribed discordant with guidelines. But note that we did not consider prosthetic joints as an appropriate criteria, nor did we consider any prevention of postoperative complications in our criteria. And I know this number seems really high, but putting this number in context, when we look at the entire body of literature of appropriateness of antibiotic prescribing, this is very similar to what we see for specific viral respiratory infections, such as acute bronchitis, where over 70% of patients receive an antibiotic. So let's talk next about prophylaxis for post-procedural complications. And I'm primarily going to focus on tooth extractions and dental implant placements here. So there have been some meta-analyses that have weighed the evidence looking at the effectiveness of antibiotic prophylaxis prior to tooth implants. One is a Cochrane review, and one was published a couple of years ago in the Journal of the American Dental Association. So the older study, published in Cochrane, found that it might be sensible to suggest the use of a single dose of 2 grams of amoxicillin prior to implant placement. And the number needed to treat here was 25. This means that 25 patients need to be treated with an antibiotic in order to prevent 1 implant failure. Now, when this study was repeated with some additional individual level studies, the authors here recommended that results may not warrant the routine use of antibiotics in patients who are healthy. And these authors determined a number needed to treat not only at the patient level, which was 24, meaning that 24 patients would need to be treated in order to prevent 1 implant failure, but they also looked at the level of the implant, because patients can have multiple implants placed at 1 visit. And if you have multiple implants placed at 1 visit, not all of them will fail. So when they did the analysis at the level of implant, the NNT was higher, meaning that 43 implants need to receive antibiotics in order to prevent one implant failure. So what about for tooth extractions? So this Cochrane review was actually recently updated just last year. And this paper looked not only at preventing infection, but also at preventing dry socket. If you've experienced dry socket, it's a very painful condition that occurs post-tooth extraction. So when we look at the primary outcomes of this meta-analysis, the number needed to treat to prevent infection in third molars or wisdom teeth that were impacted was 19. So 19 patients needed to be treated in order to prevent one post-extraction infection. But the NNT was quite high for preventing dry socket at 46. And overall, there was no difference identified between those groups that received antibiotics versus those that did not receive antibiotics in having systemic signs of infection post-extraction, including fever, swelling, and there was no difference in oral pain. These authors also identified a number needed to harm, that 32 patients needed to be treated in order to experience one adverse event. So overall, based on these numbers that I just presented to you, the authors concluded that clinicians should carefully consider whether treating healthy patients with antibiotics to prevent infection is likely to do more harm than good. So you probably noticed when I talked about implants and extractions, the authors of those studies talked a lot about healthy patients and that their overall conclusion likely reflected treating a healthy patient. So I wondered, well, what's actually happening in the literature so that we can inform our work primarily at the VA, a veteran cohort, which has multiple comorbidities. So Cochrane reviews and other meta-analyses typically only include prospective randomized controlled clinical trials. So I wanted to see what was being published in the observational literature. So we did a literature search just of the last few years to look at the prevalence in the real world and observational data of how antibiotics are being prescribed. And then the proportion of those patients who experience a post-extraction infection in those that do and do not receive antibiotics. And basically what we found in the observational studies, which are the first, third, fourth, and fifth rows of this table, is that surprisingly, I was actually a little surprised to see that a higher prevalence of patients did not receive antibiotics, and that overall infection was quite low in the majority of the studies, but that there was no difference identified between groups whether or not the patients received an antibiotic. And again, these cohorts included patients with and without comorbidities. The first row is a study from my group, which was entirely, it was exclusive to our veteran, our nation's veterans. And consistently across these studies, increasing age, higher ages, and extraction complexity was associated with post-extraction infection. Unfortunately, there are no guidelines in the United States to help us determine in which patients, in which subgroups should antibiotic prophylaxis be provided prior to implants or extractions. So we are currently reviewing guidelines available worldwide for these two conditions. And the country that's most closest to the US with similar oral health and similar use of the dentist is the UK. And their guidelines for implants state that that prophylaxis is not routinely recommended when an implant is being placed. except where bone augmentation is part of the implant placement. Similarly, antibiotic prophylaxis prior to tooth extraction is similarly not recommended. And this includes for preventing dry socket, unless the patient has signs of a spreading infection. And the recommendations are also similar in patients with impacted wisdom teeth or who are having surgical extractions of their teeth. Prophylaxis is still not recommended. So I probably presented some confusing recommendations because there is some literature that does support antibiotic prophylaxis in patients who are not healthy, looking at these Cochrane reviews, or and then other guidelines in other countries which do not recommend prophylaxis. So within the VA, because we have a cohort of patients who have multiple comorbidities, we did repeat this analysis where we looked at appropriateness of antibiotic prescribing, and we broadened our definition. We used a second definition of appropriateness to include antibiotics prior to implants or surgical tooth extractions as potentially appropriate. And here we found that 28% of antibiotic prophylaxis was unnecessary. And many of you, I'm sure, in a past webinar, it's something that's been talked about, I know during Minnesota's Stewardship Forum has been talked about a lot, is the paper that described that about 30% or 1 in 3 antibiotics prescribed in primary care medical settings were unnecessary. And of course, these numbers are very consistent with that. Okay, so moving on, I wanted to talk about the newest set of evidence-based clinical practice guidelines, which is for the treatment of acute oral infections. So these guidelines are actually labeled as dental pain and swelling, but for the non-dentists in the audience, we can call them acute oral infection guidelines. Now, I'm not going to emphasize a lot dental treatment because I'm not a dentist, but I want to make sure everybody understands that dental treatment, meaning a dental procedure, whether this is a filling or a root canal, is recommended for all conditions, regardless of the antibiotic recommendation. And that these patients simply are not going to get better, meaning their acute oral infection is likely going to progress over time without that dental procedure. And that will happen regardless if the patient gets the antibiotic or not. And one of the things that we've started to talk about and explain to the non-dental audience is that dental treatment is actually source control in these patients. So the way this table is organized is the less severe acute oral infection is at the top of the table and the most severe infection is at the bottom of the table. This is similar to how the American Dental Association presents these recommendations. Now, I will say if you're a patient and you have, irreversible pulpitis, you have probably a very severe toothache, so you may not think it's not severe, but from an overall impact on the patient's systemic health, it is generally less severe. So for patients with irreversible pulpitis and apical periodontitis, antibiotics are not recommended in immunocompetent patients. If a patient has acute apical abscess and does not have systemic involvement, meaning they do not have a fever or they do not have swelling, and dental treatment is available, so the patient is currently at the dentist's office, at the dental clinic, and they're undergoing a root canal right there, they do not need an antibiotic. Now, the general recommendation is that dental treatment should be available within 2 days. If dental treatment is not available within 2 days, the recommendation is to prescribe penicillin or amoxicillin or in patients who are labeled as being penicillin allergic, cephalexin, or azithromycin. Now, in patients who have acute apical abscess with systemic involvement, this can be life-threatening. The patient should receive an antibiotic and immediately receive dental treatment or a dental procedure. So there's a couple things that are a few things in these guidelines which are very new information to dentists that I wanted to highlight. First, this issue of prescribing cephalexin to patients who are penicillin allergic. And again, the panel of which I was on recommended prescribing oral cephalexin, oral azithromycin, or oral clindamycin, with the caveat that clindamycin is associated with significant harm to our patients. And again, these guidelines include a flow chart to guide the dentist on when a cephalosporin is safe to prescribe. And I'll show you some of those flow charts later in the presentation. So before we move on and talk a little more about a couple of the new pieces of information in these guidelines, I did want to present just that, you know, if you're thinking from a programmatic, stewardship programmatic standpoint of where you want to focus your efforts with dentists, you know, dentists are largely concordant with these guidelines, where over 80% of irreversible pulpitis and apical periodontitis were guideline concordant, meaning that patients did not receive an antibiotic. And while we were not able to assess for systemic symptoms, all of these patients had access to a dentist in this particular cohort. We found that only about 1 in 4 patients with acute apical abscesses received an antibiotic. So dentists are largely concordant with these guidelines. However, one area for improvement that we did identify was that 40% of the antibiotics prescribed here were prescribed for 8 days or more. And again, the guidelines recommend a 3 to 7 day supply of antibiotics for these patients. So that's one area of opportunity for improvement. So a new addition to these guidelines, which is probably new for dentists, it's a recommendation now to reevaluate patients within 3 days when an antibiotic is prescribed, and that patients should discontinue antibiotics 24 hours after the patient's symptoms resolve. And dentists are typically used to prescribing about 10 to 14 days of antibiotics for these infections. So this is very, very new information. But there is literature in, there are published studies in the dental literature that have found that penicillin, amoxicillin clavulanic acid, and azithromycin have been demonstrated to be effective with only a 3 to 5 day supply of antibiotic for acute oral infection. And the thing that we're emphasizing within our own stewardship initiatives is that each additional day that a patient takes an antibiotic increases the likelihood of an adverse event by about 8%. So if a patient receives a 14-day supply of an antibiotic and they're feeling better by day 3, that's probably 10 days extra of antibiotics. And they've increased their likelihood of a future adverse event by about 80%. And sorry, that's an adverse event while they're taking the antibiotic or after they take the antibiotic. So I know we were all taught, well, patients should finish their antibiotics. That's what I was taught. I agree. That's what I was taught as well. But the issue here is that we don't know how long to treat most infections. This is based on when antibiotics were first available and patients started to get better. They started to notice patients getting better at day 10 or day 14. And that's why we always prescribe 14 days for pneumonia, for example. And now the pendulum is swinging a little bit to recommend that antibiotics be discontinued based on symptoms, based on when the patient's feeling better. We actually have literature to support this with many, over 120 randomized controlled clinical trials for 17 different conditions, which has found that shorter duration of antibiotics is equal or sometimes even better than treating patients for long durations of antibiotics. So if you look in about the middle of the table, you can see gram-negative bacteremia can be treated for a shorter duration for only 7 days versus 14. So it seems highly plausible that we can treat acute oral infection for a shorter time period than shorter or at least as long as gram-negative bacteremia. And just know that there's literature supporting this, as well as statements from the WHO, the CDC, as well as professional organizations that have updated their guidance about how patients do not need to finish their antibiotics. All right, and what about the risk versus benefit? So while there are risks of antibiotic use, such as side effects and allergic reactions, from a dentist perspective, there's also benefit. The newest literature shows that less than 1% of patients have a post-extraction infection or an implant failure, but these are still inconvenient and painful events to our patients. But it's also really important to look at our serious risks and our serious benefits. And of course, all of these events, including C. difficile, resistant pathogens, infective endocarditis, are associated with mortality. And prosthetic joint infections, while not associated with very high mortality, are associated with significant impact on our patients' quality of life. And I know that's true for these other infections as well. It's just been highly demonstrated with the PJI literature. So when we look at the benefit of antibiotics, it's also very important to think about the risk and the prevalence of these events as well as mortality. So I referenced earlier that the ADA did some very innovative things with their guidelines, and they incorporated stewardship principles into their 2019 guidelines for acute oral pain. And they incorporated some text to dispel two commonly held myths by dentists. First, that short-term antibiotics, such as those used for prophylaxis or only for a few days, do not cause adverse events. And not only did they calculate some data on the prevalence of resistant infections and C. diff, but they also reported on several studies that did find that antibiotics, even when used for short duration, are associated with risks. This includes a study that was actually done in your great state of Minnesota, which found, based on your C. difficile surveillance study, that 15% of community-associated C. difficile in Minnesota was attributed to an antibiotic prescribed by a dentist. And in England, it's been reported that single doses of clindamycin are associated with fatal and non-fatal adverse drug events. And C. difficile was the most frequently cited event. But dentists are generally isolated from these events because patients typically seek care from the emergency department or from their primary medical provider when they experience one of these adverse events. So it's important that we continue to talk about the possibility of harm from antibiotics prescribed, not only to dentists, but other clinicians as well. So the second myth that the guidelines discussed was that antibiotics improve oral pain and swelling. And antibiotics do not improve pain. They do not improve pain intensity at 24 hours or a patient's pain experience 7 days post oral infection. And this is true in patients with apical periodontitis, as well as in patients with irreversible pulpitis. Antibiotics also are not analgesic sparing. I hear this all the time. I prescribe an antibiotic so my patient won't take as much of an opioid. That's just, again, not true. Antibiotics do not equal patients take fewer acetaminophen with codeine tablets or fewer ibuprofen tablets. So the recommendation then in these guidelines is to treat pain associated with acute oral infection with ibuprofen 400 to 600 milligrams and acetaminophen 1000 milligrams. Of course, assuming your patient doesn't have any contraindications. And these are recommended in the guidelines. Now, this is the flow chart that I referred to earlier for immunocompetent patients on the left, where dental treatment is available within 2 days, and on the right, patients where dental treatment is not immediately available greater than 2 days, and where antibiotics are recommended. These flowcharts are available for free on the American Dental Association website and does continue to go down to talk about prescribing cephalosporins in patients who are labeled as being penicillin allergic. And also, just to make you aware, the American Dental Association will be publishing acute oral pain guidelines focused on prescribing opioids versus NSAIDs in 2023. All right, so what about antibiotic stewardship in dentistry? So there are similar and unique factors to antibiotic prescribing by medical clinicians and dentists. These factors include the influence of our patients on prescribing decisions, access to healthcare, and the patient and provider relationship. However, unique factors to antibiotic prescribing by dentists include the availability of guidelines as well as information to inform their prescribing decision. I talked earlier that there are no guidelines for antibiotic prophylaxis for extractions or for implants. If the procedure is possible, some patients with these infections are not able to open their mouth or may have just frank swelling, oral swelling. And then the dentist perceived skills at doing the procedure that's needed for the patient, especially under emergency circumstances. And then also, dentists have a lot of competing demands in managing patients who were scheduled, who had a scheduled appointment, and seeing those patients on time, but also having some flexibility for those patients with an emergency to get in and get care. So there have been some tested antibiotic stewardship strategies in dentistry. In Europe, there is currently a multi-center study underway testing the effectiveness of audit and feedback. And then long ago in Europe, about more than 10 years ago, dentists were provided CE to conduct self-prescribing audits and participate in education. In Australia, education has been done, as well as an online prescribing tool with a decision support component was provided. In the US, there's been a study in Ohio that did a series of educational sessions. And the same group also did a consensus program between dentists and orthopedic surgeons. We implemented the CDC core elements of outpatient antibiotic stewardship at the University Dental School. And then there's also been toolkits, nudge posters, including from Minnesota, which is the poster that's shown in this slide here. And there's also some educational programming available from the CDC specific to dentistry. And then there's also statements by professional organizations recommending the implementation of antibiotic stewardship in dentistry. And we know that we have some improvement here in the United States because when you compare antibiotic prescribing for dentists in the US versus in Canada, England, and Australia, US dentists have twice the prescribing rate. However, again, we have similar oral health among these 4 countries, as well as use of the dentists. So what can dentists do today? Dental practice is different, where the majority of dentists practice in independent, privately owned clinics and not an integrated healthcare system. So what can dentists do? They can prescribe first-line antibiotics when they are indicated. And most of the time, this is amoxicillin. If the patient is penicillin allergic, they should consider cephalexin or azithromycin and totally discontinue prescribing clindamycin for prophylaxis. Dentists should encourage the identification of true allergies and increase the documentation of their patient's reaction when the patient had the penicillin allergy. Dentists should also prescribe shorter courses of antibiotics and only prescribe prophylaxis for each dental appointment. And dentists should also educate medical clinicians on appropriate indications for antibiotic prophylaxis. And we need to make sure that dentists have the space to do this because dentists are the experts. And I should also add that for those of you in acute care, dentists should also be brought into your stewardship program to help educate the orthopedic surgeon that antibiotic prophylaxis is not needed in those patients with prosthetic joints. And I also think that dentists can be a real resource for medical clinicians because something that medical clinicians struggle a lot with is the management of toothache and oral pain when a patient presents to the ED or primary care clinic with a toothache, and our medical clinician colleagues simply do not have the tools to appropriately treat that patient's acute oral infection with a dental procedure. So I'd like to acknowledge my collaborators on the research that I presented to you today, as well as my partners, the ADA, the Illinois Department of Health, the VA Antimicrobial Stewardship Task Force, the Office of Dentistry, and the Oral Health Quality Group. So I thank you very much for your attention and for your patience as I drank lots of tea and water during that presentation. And I'm going to stop sharing my screen so I can look at the chat for questions. So I'm not seeing any questions in the chat, but I will take a moment to see if anybody enters any questions.
Thank you, Dr. Suda. And I just wanted to remind everyone as well that if you would like to verbally ask a question, you can raise your hand in the WebEx panel of participant panel. So feel free to do that as well as using the chat box.
Thank you for that wonderful presentation, Dr. Suda. This is Mohammed. I actually have a question kind of just to start us off. Since we have several pharmacists and other clinicians attending this webinar, what would you say kind of are the benefits or kind of opportunities for collaboration, across dental, medical, and pharmacy professions to promote and advance dental stewardship?
Thanks for that question, Mohammed. So I think first, if it depends on if the person's practicing in acute care or in the community. So for acute care, all of us have dentists on staff, and dentists may not be as involved in the direct care, but many dentists perform dental procedures in the OR of our surgical suites, as well as oral surgeons do as well. And an opportunity is to have those dentists and oral surgeons on staff become engaged in your stewardship program, including things like engaging with the ED and management of toothache, and also is starting to have those conversations with your orthopedic surgeons. And then in the community, getting out these information on guidelines. Even though these American Dental Association guidelines were published in 2019, we're still finding that it's new information for dentists. So getting those guidelines out. Similarly, the AHA, infective endocarditis prophylaxis update that was published last year. Similarly, dentists are just not aware of those updates. And I'm not sure cardiologists are really as aware of those updates as well. So trying to discontinue clindamycin use for prophylaxis. So I see one question in the chat is how would I advise approaching physicians, for example, orthopedic surgeons who still feel their patients need pre-medication of antibiotics? Yeah, so this is a hot topic and something we are talking about as well. So first, there was a paper published in JAMA Network Open, and that paper was published by a US English group. And in the UK, there's not been a recommendation to use antibiotics in patients with prosthetic joints. And that study, again, found no association in the UK where antibiotic prophylaxis is not used between dental procedures and prosthetic joints. So there's simply no link between those two groups. If that doesn't help, there is associated, these antibiotics have been associated with harm. And then the other thing that we have started to do is to talk more about the old guidelines. So the old guidelines that were published, I'm forgetting the year, but I can look it up real quick. I think they were, the last version actually did not recommend antibiotics in all patients with prosthetic joints. And that's a misconception. It was only very certain patients. So patients within the first 2 years, patients who were severely immunocompromised, and a few other patient groups that I'm forgetting, but there's a very nice table that lists those out. So even before the guideline change of no antibiotics, it was not recommended. Something that has been successful by that was published in the literature was coming to consensus between dentists and orthopedic surgeons, and that paper was published by Debbie Goff. It's published in Clinical Infectious Diseases, so you should be able to find it if you look it up. If not, feel free to email me and I can send you the citation. So another question is, do most dental schools in the US now include a focus on antibiotic stewardship as a result of these findings? So thank you so much for that. I would love that. And I believe there is some movement. The American Dental Education Association recommends that antibiotic stewardship be incorporated in the curriculum, as well as implemented in their dental clinics. So Kayla, I think you probably found yourself a great project, and I'd be happy to help you with that. But not yet. But there was a survey done a couple years ago, which did try to collect some baseline information of how many dental schools are incorporating stewardship.
I'd just like to add to that. It was interesting to see the comparison between the US, the UK, Australia, and Canada in terms of prescriptions with kind of almost the same outcome. What do you think the main cause of that would be? And we just have like a minute.
Yeah, well, first of all, our guidelines are different, and our prescribing culture is different. But also, it's a little more of a conservative approach in other countries. Similar to opioids, dentists in the US prescribe way more opioids than in other countries.
All right. I think we're about at time. Thank you so much, Dr. Suda, for that great presentation. We really appreciate having you present your knowledge, and thank you to all the participants who joined us today. And we hope you all have a wonderful rest of your day and happy Thanksgiving. And that's that. Adjourn.
Thank you all
Anything
for your
else?
participation.